Our next speaker is Lorraine Johnson. Lorraine Johnson is an attorney advocate on issues related to the medical, legal, and ethical aspects of Lyme disease, and she has published over 30 peer-reviewed articles on the topic. She earned her JD from Loyola University and an MBA from USC. Probably everybody in this room knows LymeDisease.org, and Lorraine is the Chief Executive Officer of LymeDisease.org and the Director and Officer of the International Lyme and Associated Diseases Society. She is the co-chair of the Consumers United for Evidence-Based Healthcare, a nationwide coalition of consumer groups associated with the Cochrane collaboration. She's also a member of the International Cochrane Consumer Network and serves as a consumer peer reviewer for Cochrane Collaboration evidence-based protocols and reviews. Evidence-based medicine is a big deal. She has spoken before state legislatures, the CDC, at the Canadian Government Consensus Hearings on Lyme disease, and at the IDSA Review Panel hearing, and before the Cochrane Consumer Network. Lorraine is one of the extraordinary leaders in the field who has dedicated her life to developing through research, collaboration, and study the concrete information that is essential if change is to occur. Whether you realize it or not, if you are touched by Lyme disease, Lorraine Johnson has been fighting for you for a very long time. Please welcome Lorraine Johnson.
Thank you for that wonderful introduction. I'm really happy to be here today and to see so many people gathered together who are concerned about what's going on with Lyme disease. And what I'm going to talk about today is going to be a bit about the financial burden of the illness. So when we talk about the financial burden of the illness, what are we talking about? I was preparing for this presentation and I remembered back to a documentary that was done by Sting just as he was leaving the group, The Police. And he had a lot of cameramen milling about. They were focusing on one musician or another. The group had never really worked together before. And it was a chaotic and interesting scene, and your eye flitted from one person to another. And finally, Sting went up to the center of the stage and he looked at the cameraman and he said, "I want you to keep your eye on the money." And with that, the room sort of settled down. And that's basically what I'm going to be talking about today, is the financial burden of this illness and putting that in some context. One of the things I'm going to talk to you about today is some of the studies that we've been doing at LymeDisease.org. We've been doing broad-scale surveys of populations. Our last survey drew over 4,000 responses from patients with chronic Lyme. That survey was published in Health Policy. We did that in connection with Stanford. And what we did when we launched the studies was we asked a series of questions to determine who was going to actually be in the study. So we asked people, have you been diagnosed with chronic Lyme disease? And then we asked, if you've been diagnosed with chronic Lyme disease, was that confirmed with a laboratory test? And we used those two factors for being included in the published study. And then we also asked patients whether they had been treated with a 30-day protocol recommended by the IDSA, and if so, if they had failed that protocol and remained ill for 60 days. So that was essentially our definition of chronic Lyme disease. So I'm not going to get into a lot of detail. This is a pretty scary slide. But what I wanted to point out is this is basically the spectrum of the disease. If you look at this broad bell-shaped curve might be the spectrum of the disease. And if you were doing a study, what you would love to have as your sample is you would love to have that little blue curve right in the middle, or maybe that golden mound. Both of those are crossing the mean, so you're pretty assured if you get that population that it's a population that's representational of the disease. But a lot of times what you get is you get something that looks more like that little turquoise cone. And what that turquoise cone is a much more narrow population. So, for instance, when you look at your randomized controlled trials in Lyme disease, we know that in Dr. Fallon's NIH study, he screened 3,600 patients to achieve a sample size of 36. That's a highly selective sample population. It's probably something that would look like that turquoise cone. And, you know, when you do a survey population, survey populations also have their limitations. People who respond to surveys are a certain group of people. So although I think with the 4,000 responses we got a much broader representation of the disease, I don't think it's fully representational. It doesn't include people of early Lyme disease, for instance, people who've just been diagnosed. They probably aren't even going to know that we're doing a survey or go out there and take it. I think the patients who respond to our surveys have been sick, and they've been sick longer. So that would be something to keep in mind when you're talking to researchers and you're talking to patients or you're talking to their treating physicians and you're talking about chronic Lyme disease. You may be talking about apples and oranges, which has been pointed out, and I think that's a good point to keep in mind as we go through. So I'm going to talk about what's going on in the healthcare arena generally, what we're doing in terms of healthcare costs, what the focus is in terms of chronic illnesses, and the need to get healthcare costs under control and how that might impact Lyme disease. So over the past 10 years, healthcare costs have doubled. And when they doubled, we realized there was a real crisis, a real fiscal crisis in terms of healthcare costs. So one of the first questions was, well, what are the major components of this cost? How can we control these costs? Which are the factors that would be the most important for us to pay attention to and try to get costs under control? And what they found was that 84% of costs were incurred by chronic illnesses. In fact, over 90% of prescription costs and around 80% of physician visits are caused by chronic illness. And of people who have a chronic illness, about 25% of those also have an activity limitation. So an activity limitation might be I can't work or I can't go to school. Those are functional impairments. And they found that those people have got twice the health care costs as those with chronic illnesses. So if you're just looking at the health care cost equation, people with chronic illnesses are costing more money in terms of health care costs regardless of what they're being treated for. And people who've got a chronic illness with an activity limitation are incurring 2 times those amount of costs. So if you're focused, you'd really like to focus on chronic illness, and particularly you'd like to focus on chronic illness with an activity limitation. And if you look at the really large pie of what the costs are in chronic illness, it turns out that only 21% of the cost of chronic illness, or this is actually of illness in general, a cost of health care in general, is attributable to treatment costs. The remainder, roughly 80%, is attributable to lost economic output. And by that, what they're talking about is they're talking about people who can't work, people who can only work part-time, people who've had to take a lesser job because of their illness, people who are calling in ill, or even people who show up for the job and perform poorly because they're feeling ill. That's called presenteeism, and it has a cost associated with it. So if you were just looking at the big picture here, you could see that a $1 bet on treatment costs could save you $3 in lost economic output. It sounds like a good economic strategy. So let's step back and ask the question whether Lyme is a chronic condition. And there's a lot of debate about what the cause of Lyme is, the etiology of Lyme. Is it caused by an infectious agent? Is it caused by an immunological response? But I'm not going to address that issue. I'm simply asking the question whether it's a chronic condition. And there are a lot of different definitions that are used to describe chronic conditions, but the one that seems to be prevalent right now, this seems to be where healthcare policy is moving, is one that's more economically based. And basically what they're looking for is this an illness that has lasted for 12 months or more? And does it result in functional limitations, including loss of ability to work or go to school? And does it have an ongoing need for medical care? So we went out and we asked the patient community this question. And the answer was that 95% of the respondents to our survey had had Lyme for 2 years or more. And if you go all the way over to the right side of the slide, you'll see that 47% had had it for 10 years or more. And these numbers are in keeping with the randomized controlled trials of Klempner, which found that the patients enrolled in that study had had Lyme for an average of 4.7 years, and Fallon, where they found that the patients had had that for 8 years. But does it result in functional limitations for the patient? Well, when we asked this question, we found out that 65% of the respondents had to cut back or quit work or school at some point in their illness. And as you can see here, 44% had to quit work. Quitting work is a very big deal. Even if you're able to subsequently go back to work, you may find you can't find yourself in the same rung of the ladder that you occupied previously. And how long were these people unable to work? Well, 28% had been unable to work for more than a year, and 8% had been unable to work for more than 5 years. Of the respondents to our survey, 25% had been on disability at some point in their illness. And the length of time that they had been on disability, 75% had been on disability for more than a year. If you go all the way over to the right column, you'll see 37% had been on disability for 5 or more years. This is a very costly illness. So keeping our eyes on the money, what is it that they're doing in other chronic diseases to try to control the healthcare costs? Well, they're looking at a concept called compression of morbidity. And what essentially they're doing is they're saying, let's make sure that people aren't at risk for the disease. And if people become at risk for the disease, let's make sure that we intervene to make sure that they don't get the serious form of the disease. And if they go on to acquire the serious form of the disease, let's get in there and treat it aggressively so that the people are restored back to their prior productivity, and so that we can reduce physician costs and hospital costs. So I'm just going to give you an example of a disease this is applied to that everybody can relate to, and that's diabetes. So in diabetes, for primary prevention, the first thing you would do is you'd say, don't get the disease. We want you to exercise and we want you to eat a good diet so you're never at risk of getting the disease. If you go on and you develop high blood sugar, we're going to go in and say, we would like for you to now diet and exercise so that you don't develop full onset diabetes. And barring that, if the person goes on and gets diabetes, you're going to go in and say, let's treat it aggressively. We want to keep these people out of the hospitals. We want to make sure that their physician and prescription costs are lower. And we want to restore them back to their prior productive lives. So how are we doing with Lyme disease? And I think this is really critical because I think we're failing on pretty much every beat. In terms of awareness, we're doing things like telling people it's not a problem in this state. Don't worry about it. It's not even on the radar for a lot of people who go hiking. It's not on the radar for the physicians that they go to see when they have a rash. Everybody waits for it to just go and resolve, and it will eventually. But that would be the very first place to avoid people being at risk of acquiring, and I'm really focused on chronic Lyme disease because I think that's, it's essential to prevent the person from developing Lyme disease and to prevent them from getting chronic Lyme disease. Person came in with a tick bite, or a person comes in and has a rash. Right now we're defaulting on the side of, well, we're not sure, let's not intervene. No, really we ought to be intervening because the cost of not intervening is putting the patient at risk for developing chronic Lyme disease, which is very costly and can have a profound effect. So I think we have a long, long way to go, and what we're finding right now from the results of our survey was that patients are seeing too many physicians. 50% see 7 or more physicians before they're diagnosed. That goes to the issue of physician awareness. 30% are traveling 100 or more miles for treatment. That means that, for one thing, there's a scarcity of doctors treating Lyme. I think there's a climate of fear. Physicians put themselves at risk if they go out and they treat Lyme disease. And it's taking way too long for diagnosis. 84% of the people who responded to our survey were not diagnosed within 4 months when the disease is much more treatable. And if you go all the way to the end there, you'll see 36% had not been diagnosed within 6 years. So this is, and by the time they're actually diagnosed, they're too sick. So this is a self-reported health status. It's a question that the CDC goes out and asks annually. They ask it of the broad population. And the blue bars represent the CDC's responses, and the green bars represent the Lyme responses. You can see they're almost exactly the opposite. But what this shows us is that in the normal population, the overwhelming majority of people self-report that their health status is either excellent or very good. And in the Lyme community, the vast majority of people report that their health status is fair or poor. And that's, again, that would be something that conforms with the Klempner disability equivalent to congestive heart failure. The other thing that they have found, because the CDC does this study on a broad-scale basis and has done it for over 10 years, they found that with each degradation in reported healthcare status, there are additional medical costs incurred. So this is another factor there that you consider when you're looking at healthcare costs. So we have the responses from the randomized controlled trials regarding treatment efficacy, which were, as Pam mentioned earlier, there were mixed results from the trials that have been done. But we went out and we asked the Lyme community what their response was. We specifically asked, were you treated for 30 days with antibiotics once you were diagnosed? And if you were treated for 30 days with antibiotics, was that restorative? And if that wasn't restorative, did you go on to get additional antibiotic treatment? And if so, was that helpful? And what we're seeing here is that over 50%, around 40% of people were saying that they felt that the antibiotic treatment made them much better. You know, the continued antibiotic treatment beyond the initial 30 days, and 30% felt that it made them somewhat better. So patients are self-reporting improvement, and that's an important factor to keep in mind when we consider what to do when people are remaining ill. So I think we have a wake-up call, and I think that what we have found is that our current strategy of dealing with Lyme disease, I would call minimal intervention. When in doubt, don't. I think that that strategy has failed miserably. I think it's resulted in more and more patients developing chronic Lyme disease and the additional costs associated with them. And I would suggest that what we do is that we now adopt a policy of aggressive intervention. Let's err on the side of getting early diagnosis. Let's err on the side of getting aggressive and adequate treatment for the patients so that they're not at risk of having chronic Lyme disease and the effects that it has on their lives. Thank you. Next slide, please. And this is my last slide. But I think we have a real crisis of compassion. It's really disturbing to me. This is a quote by Dr. Phil Baker, who headed the Lyme disease area with the NIH. No one disputes that these patients are suffering, but the response to that was to adopt a do-nothing strategy. And I think that we have a growing area of fiscal irresponsibility now, and I just want to point out that recently there has been adopted a very aggressive campaign for Alzheimer's. I don't know if you've been reading about it in the news, but essentially what they've done is they've decided that they can no longer afford to ignore the growing financial burden of the illness of Alzheimer's. And they've decided to go and aggressively start doing research, looking for early diagnosis, and start looking for treatment. And here's what they said. They said, beyond the suffering, it's a budget-busting disease for Medicare, Medicaid, and families. And I think that that same approach applies to Lyme disease. I think that that's what's going on here. It's sort of a silent thing that we're not paying attention to. And the last point that I'd like to make is that ignoring consequences of a decision to intervene or not intervene is not an effective strategy. It hasn't been an effective strategy for Lyme patients.